Hello, everyone. Welcome to the show. I'm your host, Ernie De Los Santos, founder and faculty chair at Appeal Academy and creator of Top Gun Audit School. And we are live on the February 5th, 2016 edition of Finally Friday. And I can't get my slideshow started here. Here we go. Come on. Any day now, computer. I'm telling you all, if you haven't heard me say it before, computers have a sense of humor, and it's very sick. Why is it doing this to me, Bill?
I have no idea.
That's not the right slide.
Join Me has been acting up all day.
There you go.
You're changed.
Okay.
There's a theme song. It's trying to load a theme song.
Yeah, I can never get the audio to play over these rooms, but okay, so let's see. Wait a minute. Now, why is it? I still don't have the slideshow coming up. I love technology. We've had problems with technology all day today. Let's see if I can get the slideshow to finally start. Okay. What do you know? Finally, we're here. Okay. So we're live on the February 5th, 2016 edition of Finally Friday. And if you have any question about whether it's live, you know now definitely we're live. Anyway, I want to thank you for choosing to spend your time with us here on Finally Friday. Today's Finally Friday broadcast is sponsored by the Health Law Partners, providing solid advice and real solutions for healthcare business nationwide. Also by Recovery Analytics, that's Sharon Easterling's company. And then we're also sponsored by MedLinks Cost Containment. They are the makers of Healthcare Audit Tracker. You can visit zerodenials.com today to see how they can help you track audits and greatly reduce or even eliminate your denials. Another sponsor is Aerolib Healthcare Solutions. That's Dr. Fahuja's company out of Dallas, Texas. They are a patient-centered total quality management consulting firm. They are the makers of the Physician Advisor's Guide DVD, now available as a DVD or on demand. And our other sponsor, last sponsor I'm going to list today, is the Council for Certification of Medical Auditors, or the CCMA. They are the creators of the widely used Certified Medical Audit Specialist Certification, or CMAS. You can learn more and earn more. Visit their site. Okay, so today we're going to hear a brand new presentation from Dr. John Zelem. He's Vice President of Clinical and Regulatory at Executive Health Resources, or EHR, as we all know him. Dr. Zelem is a general surgeon with over 26 years of experience. Now he's a fellow of the American College of Surgeons and is responsible for quality assessment improvement at EHR's client hospitals. He goes to hospitals regularly to provide medical executives and staff members with ongoing education on many topics, such as Medicare and Medicaid compliance and regulations, medical necessity, recovery audit contractors, utilization review, denials management, and length of stay. So buckle up, my friends. We have a rock star with us today. Okay, so I also have my loyal and faithful co-hosts on hand. Sharon's supposed to be with us. Might have lost her. Sharon is an auditor. Okay, yeah, as usual. She's an auditor, speaker, and appeal writer, has her own company, Recovery Analytics. And then my other co-host, Bill Malm, who's a practicing clinician, speaker, and a certified medical audit specialist. So thanks to all of you for joining me on the show. Anyway, first I want to make clear that the opinions shared on this show are those of the panelists, not necessarily representative of their employers. My opinions are also mine and mine alone and no one else's, and especially not those of my sponsors, or at least not necessarily. Anyway, before we get started, let me switch over to the website, because we have a good number of people on today that may be new. So what I want to do is switch to the website. I do want to, I keep trying to tell people you still listen to our theme song. I can't make it play during the show, but you can find it on our website under Fun Stuff on our website right there, and it comes in. It's only, it's only a few minutes long, and it's very fun. Your revenue cycle team will really enjoy it, I guarantee. So anyway, let me tell you, if you are new to the room, anytime you're on Appeal Academy, you can go to this down the right side of any page, and you'll find these green buttons. You click on that, it'll open a page that gives you complete instructions on how to use the control panel that you have that appears on your screen during the call. It tells you how to get audio connections, but if you're listening to this, you don't need to know that. Chat box, you do want to open that because we very often had, I see somebody in the chat box was asking for the phone number. Yeah, and then somebody gave it to them there. So that's in the chat box. There's often a very different conversation going on in the chat box, and that's if you have questions or comments during the show, that's where you enter them, and we watch that as we go through, and we interrupt and go through it. This is a discussion, not necessarily a lecture, although Dr. Zelem has a really good lecture prepared, but so I'm going to try to rush through everything here at the beginning because I really want to give him about 40 minutes to do all that alone. Anyway, then there's also a way for you to zoom in and out on the screen if we're not zoomed in enough on something for you. Zoom in, zoom out, don't get dizzy. There's a participants list, which you can identify yourself. This tells you how. You can do that or not. Some people do, some people don't. Doesn't matter to me. So you know the chat box is not recorded. The show is recorded, so you get all the audio and what's on the screen is recorded, but the chat box is not. Although I do ask everybody to please remember to keep it professional in there because we have lots of different kinds of people there and everybody can see the chat box. Okay, no, I'm not going to give you control of the show, so you can forget about asking for control of the room. Okay, I think that's all. If you haven't gotten the handouts yet today, you can go to appealacademy.com, go to This Week on Finally Friday, and there is a box down in the middle of the page right here, this blue box. You just put in your email, and it gives you a zip file with my PowerPoint as well as Dr. Zelem's PowerPoint, which is separate from mine, and that's all EHR branded and everything. It was a little different format, so I didn't just incorporate it. Anyway, I do want to remind everybody that is a copyrighted material from Dr. Zelem, so if you want to copy it or use it in some way or replicate it and distribute it, you do need written permission from EHR. And the PowerPoint on the last slide does tell you how to do that. Anyway, so all that's out of the way. Okay, I guess we are ready to go. All right, let me get back to the slideshow. And a couple things to go over, and I'm only going to take a couple of minutes because I want to give Dr. Zelem plenty of time. Last week we talked about, we were particularly talking about why do we have to keep chasing all these regulations, and then there's MA plans, and why do those darn things keep changing, and there's a fear of controlling drug pricing by negotiations, and we had a great discussion about that last week. You can see that on the website. This week, of course, we are talking about cloning. And I, posed the question in my emails about why does CMS spell it ILLEGAL. So the name of Dr. Zelem's presentation is copy forward. Is it also permissible? So we'll get to that in a minute. Let me just show you a couple of things. I'm not going to go all the way through these so you can read them yourselves later. But there was a couple of things in the news I thought I would bring to your attention. These are not things that get much play, but here's an article that's about how the OIG's corporate integrity agreements, they are producing more and more of these. There were only 35 in 2012. Last year they enacted 53 of them. So that's going up. And if you study those CIAs, you can find out exactly what the OIG is really focusing on and how they think things ought to be done. So it's a good way to do that. That article will give you some information about that. There's another article that was about the Bipartisan Budget Act of 2015 and how that changes how outpatient off-campus outpatient departments are going to be paid in the near future. So that's something we haven't talked about before. We'll probably talk about it in the future, but I wanted to give you this so you can see this article and you go look at it yourself. One other thing is CMS, we had talked in the past couple of weeks about how You should go comment on the quality reporting measures that CMS has been asking for comments about. Now, there's 99 questions for you to answer, and it seemed to me like, to a number of us, well, they didn't give you much time. Well, they've extended the time. No doubt not because I mentioned it, but just because they're not getting many comments. So go to that article and you can see how to do that, and I highly encourage you to go participate in those comments. And then this last week, there were a ton of hearings in Congress about health care, and not all of these are relevant to all of us, but there's some in here, and I just wanted to give you a list of these so you could be aware that Congress is having a lot of hearings lately. And so I just wanted to give you that list so you could go look through it and try to go find that. As I said, I'm not going to spend time on that right now, but I wanted to give you that list. So this week we were talking about copy-paste or cloning, and of course, I found some fun things to talk about. Of course, I have to have a keep calm kind of a meme about copy and paste, and then, but it really does make some kind of headaches, right? Because copy and paste is not that easy to do for some people, I guess. Even the most interesting man in the world has trouble using copy paste. And then, of course, there's other things about copy paste. There's cloning we could talk about. And I found this. I love the picture. I have no idea what this toy is about. It's a toy that's supposed to be about clones, but I just had to show you the picture. I love the picture. I have no idea what that's for. And then in my email, I mentioned, we're going to talk about the good, bad, and the ugly about cloning. There are things that I would like to clone, or I wouldn't mind cloning Adele. I have no interest in I think it's a bad idea to clone Charlie Sheen. And then, of course, the ugly thing to clone are all the denials and everything. And this morning I updated the picture a little bit because there's somebody else who I think who's even worse idea to clone would be this guy. What's Shkreli or something, Schmuckreli, I don't know what his name is. The guy who was appearing before Congress and, with a smirk on his face, wouldn't answer any of the questions. Anyway, okay, enough politics. It's time to switch over to let Dr. Zelem give us something really useful instead of my rambling. Okay, so Dr. Zelem, let me switch over to your presentation and see if I can make that work.
It's visible.
Well, it looks like it's visible. Let's see, I got to get rid of that one and go to, it's not cooperating with me today.
You didn't clone it.
There we go. Yeah, right. I didn't clone it right. Didn't hold my mouth right or something. Okay, here we go. Ready to go. All right, so we'll let you discuss the agenda for today.
All right, Ernie, thanks very much, and good afternoon, everybody. I'm sitting here in lovely Connecticut where we just got a fast 12 inches of snow this morning, and to me, there's nothing that I like about snow. Put me on a golf course, and I'd be happy. And Ernie, I want to congratulate you that you actually were able to say all of those stuff and only take 5 breaths during that entire period of time.
I use a script mostly, yeah.
But
thank you.
The other thing I want to add is that you had mentioned that the presentation is copyrighted, but you'll find that almost every slide has the reference for the information that's on that slide. So I'm not the brilliant one that came up with all of this stuff. What I did is I actually took. The only thing that I did was take all of these references and the information in those references and try to put it together in some type of an understandable way of looking at it. Because I think we use copy and paste, we use cloning interchangeably, and there really are some significant differences. So as part of the background of what we'll talk about the electronic health record and the challenges of what it was supposed to do, what actually is cloning, copy and paste. And the Medicare, the Department of Justice, and the Office of the Inspector General are stepping in and taking a look at that because they realize that there's a monster that's been created and there just haven't been enough rules and regulations put into how to monitor it. So next slide, please, Ernie.
Okay.
So just as some of the background, and this comes from the Medicare Health Providers Fact Sheet, and I'm not gonna read the whole thing. You can read it in your leisure, if any of us actually have any. The cost of health care in the United States continues to rise, but the overall health of our nation is not necessarily improving or keeping pace with other countries. And there are a number of different areas where we lag behind some of the other not so sophisticated countries, and I'm not going to get into that. We have Obamacare, we have all sorts of other regulations that have come into play, but in 2009, at the American Medical Association conference in Chicago, President Obama encouraged healthcare providers to move from paper health records to EHRs. EHR being electronic health records, not executive health resources, although I will tell you, we had those initials first. Next slide.
Okay. Here we go. Come on. Here we go.
So once you've all been around, whether it be in your own institution, whether you visit multiple institutions, but everywhere that I go, I hear execs saying to me, and even VPMAs and CMOs, et cetera, saying, we have a real problem with cutting and pasting. And the best comment that I heard that was very indicative of cutting and pasting was, the chart was surprised when the patient died. And the reason why that really struck me, and I can't take credit, although I've used it 3 times, so I do take credit for the phrase, there's so much copy and pasting that day 1, day 2, day 3, it's the same thing, and all of a sudden, boom, on day 4, the patient dies, and it's like, well, I didn't see that coming. And the reason being is that because of copy and pasting or cutting and pasting. But, the question is it really cloning? Is it note bloat? Or is it both? And one of the things that you see when you start looking at records, especially now that we have these abilities, so many items get pulled in. On the history and physical, I was at the HEMA conference in San Diego 2 years ago, and they said, what is the longest discharge summary that you've ever seen? And, of course, people came up with numbers, and this reviewer said the longest one that she has seen was 125 pages. Now, that's absolutely amazing. And why does that occur? That occurs because of the notes being pulled in, the labs, et cetera. And then when you start looking at some of the fixed items have to do with past medical history, so fixed data with dates and meds, et cetera. So let's go on next to some of the details, to the electronic health record and the challenges and proposed benefits. So if you look at the Medicare Health Providers Fact Sheet, the reported benefits of the electronic health record was real-time access to complete patient records at the point of care. And one of the goals was actually to have the ability to make this information available so you don't need to repeat tests. Patient goes to another hospital, that information is available, hasn't happened. It's also to be able to provide clinical alerts and reminders which reduce and prevent medical errors. Now, I will tell you that there was a report from the Journal of Patient Safety in 2013 that said at this point there are 440,000 lives a year lost due to medical mistakes. Now, you may say, all right, that's 2 years ago. Things have really improved. They have not. Then it was supposed to help with decision support, diagnostic aids, and elimination of duplicate tests. That hasn't happened. Reliable e-prescribing with fewer medication errors. That hasn't happened. It has provided a reduction in paperwork as long as you don't want to print out that 125-page discharge summary. Next slide. So other benefits, greater coordination of care, legible records. That, I will admit, that's really been an advance. It has provided us with legible records. The ability to interface with labs, patient portals, which allow the electronic interaction between provider and patient. And recently, even some of the physicians that I go to have these apps on your phone where you can get into your data. So that's been helpful. Electronic referrals, improved coding and billing. So those are the reported benefits. Next slide, Ernie, please. But
sure.
Here are the actual challenges. has it really improved physician documentation? Well, a couple things. Number one, the electronic health record was originally meant and originally designed to help and assist in billing. That was the original intention. It is created by non-clinicians with no physician input. And the two things that were never addressed in the initial implementation of, how surprising, were the patients. That's what it's supposed to be all about, and the physician. And it's quite a challenge if you are trying to modify anything in your EHR unless you have a well-educated IT person with clinical knowledge or even a physician. But the other challenge is, so that's for individual hospitals, but it's worse for systems because they have an entire medical record for the entire system, electronic medical record, and if they want to make a change, they can't make a change for an individual hospital, and then they need to go back to the application maker, which becomes quite a task. And the electronic medical record has not been shown to increase quality of care without robust documentation tools, and they are lacking. And lastly, the end user, the physician, was really never adequately trained in its use. Next slide, please.
Okay.
And this was the most fascinating article that I ran into, and so the reference is at the bottom of this slide. But the statement, nobody really knows what's wrong with the patients. And we have templates, different pages, different tabs. Physicians run all over the record to find pieces that they can insert to today's note. So that's the pulling in. That's the note blow. They paste all of this into the records, and I realized that I put one of them twice. They try to get in every single progress note and consult ever generated, every single lab test over the past 5 years. Put that in there. There's the diagnosis list, the problem list. And we've talked about this on other shows that I've been on, is that the problem list gets copied from day to day to day with minimal changes. Now, some of the electronic medical records, if you make a change, or if you copy and paste it, the copied portion is in red font, and the only way to change that red font back to the original black font is to make a change and an edit. But I don't know if just editing a the to is enough of a change to make it black.
If you look at, if I can just interject there, Dr. Zelem, I know that out in the internet marketing world, if you look on the internet at things, Google tracks lots of websites, of course. Well, they give, they look at something, whether it's an exact copy of something else. As far as they're concerned, if it's not 30% different, it's the same. So that's that's just that in that world. I don't know what CMS thinks about, well, how different does it have to be before it's different? I don't know.
Yeah, I have not got that answer yet. But the other thing I've seen is in a couple charts that I've been reviewing, where the review of systems and even the physical exam is a templated. The entire thing is templated, and you can make changes in it. But let's just say you go to the respiratory section on the review of systems, and you change a negative to a positive. Well, that positive now turns into a red font, and I don't know how you can change it back to black, but anybody looking at that from a surveying is going to say, well, we could tell you didn't do the whole review of systems, you just changed two parts of it. And that's where the fraud aspect tends to come into this, because you're trying to get paid for work that you didn't do. So next slide is what is cloning, copy and pasting, and I decided to go. Actually, what I wanted to do is I wanted to go and I have to be careful about what images I use because they're copyrighted. And I was going to go take a couple pictures, but I didn't have the time. But copy and pasting, because if you go to the one of the next slides, I wanted to take a picture of an old jar of glue and a pair of scissors. Because when you come down to it, you'll see not this slide, but the next one. So here's what Medicare says. Documentation is considered cloned when each entry in the medical record for a beneficiary is worded exactly like or similar to previous entries. And cloning occurs when medical documentation is exactly the same form. Next slide, please.
Okay.
So we hear these other terms as interchangeable, although they're not really. Copy and paste, and they have made it sound so pretty euphemistically. What are we doing? Oh, we're going to just copy forward. Macros, and then the other thing is save my note as a template. And that gets done a lot in procedures so that they don't have to dictate it, and et cetera. And I'll give you a story at the end of a saved note as a template because it'll just amaze you. Next slide, please.
Okay.
So AHIMA is, as you know, is the big organization for CDI. And it's interesting because as I have been doing chart reviews, there's some standards that I have come up with for structural analysis of charts. And people would say to me, so what's your reference for that? And over the Christmas vacation, I was kind of searching for a few things, and I ran across AHIMA's guidelines for proper documentation and what should be in a history and physical and discharge summary, and it validated what I had been thinking. So that my thought was, well, did AHIMA steal it from me or did I steal it from AHIMA? But I didn't copy and paste it. So that was
all right.
That was supposed to get a laugh, but I didn't hear one until you finally laughed.
I laughed.
That's all I needed.
All right.
So AHIMA has said that the use of copy and paste functionality should be permitted only in the presence of strong technical and administrative controls. And they're not out there. They'd love to put them in place. The only other thing to do is to shut it off. And of course, it does serve some beneficial purposes. And the other thing is that the functionality should weigh the efficiency and time-saving benefits it provides against the potential for creating inaccurate, fraudulent, or unwieldy documentation. And I'm sure all of you have examples out there where that has actually occurred. Next slide, please.
Great.
But here's the flip side. So what if physicians, what are they saying on social media, commenting on this? And they say that the use of copy and paste functions in the EHR it actually saves time when they know they have duplicate information. And I don't see that as a problem, but you got to be careful what you bill for. Because if you bill for the same amount of time and the same amount of work and you didn't do it, that's where we start getting into that orange jumpsuit situation. Next slide.
Okay. Yeah, nobody looks good in orange. So.
or stripes lately.
Yeah.
Unless you drive a white Bronco and you could wear blue.
Yeah. Okay. I agree.
So the challenges and risks can provide inaccurate or outdated information. And I looked at some of the medical history on some of these, and it'll say when it started, when it was resolved, et cetera. But those dates can be inaccurate. Redundant information, especially when you're pulling something from 5 years ago into today's note. The other, and I've seen this a lot, the inability to identify the author or the intent of the documentation. And I've looked at some of this like, well, who really put this together? The inability to identify when the document was first created. They have this Make Me the Author tool. The propagation of false information, internally inconsistent progress notes, and unnecessary lengthy progress notes, which results to this note bloat when you pull everything in. Next slide, please.
Okay.
So just quickly for your information, Medicare and the OIG are stepping in, and here's a few of the things. So here is the volume of documentation versus medical necessity, and this really comes down to some of the things that have to do with cloning. So the Social Security Act says, and I quote, "No payment will be made for items or services not reasonable and necessary for the diagnosis or treatment of an injury or illness or to improve the functioning of a malformed body member." End of quote. Now, I have to tell you, the first time I read that, I looked at it and I said, what? What in God's name are they trying to say? But if you really break it apart and break it down to its essentials, it does make sense. So providers can over-document and consequently select and bill, and they do, selected bill for a higher level E&M code than the medical necessity or the something that is more than medically reasonable and necessary. And the other thing is, even if a complete note is generated, so you have all of this information there, only the medically reasonable and necessary services for the condition of that particular patient at the time of the encounter is documented can be considered when selecting the appropriate level of E&M service. And, again, more towards note bloat. But on the other hand, if the essence isn't there, then you really shouldn't be billing for it. And again, this is not my opinion. This comes from First Coast Service Options publication that they had in the past. So the information that has no pertinence to the patient situation at that specific time cannot be counted. Next slide, please.
Okay. All right.
So what is the potential for denials? And we're not seeing denials per se about this yet. And recently, on a lot of the ALJs that I have been doing, I'm hearing all of these things. And you talk to the judge, you talk to the auditor, and you start. And HCFA ruling 93-1 says that the entire administrative record may be used in the defense of a denial. So the information is there, but lately the judges and the auditors, who most of the time are not physicians, are taking a look and saying, well, you mentioned all these risks, but the doctor didn't document it. So did the doctor not consider it important? So the documentation is not there to support the medical necessity as it's being looked at. And, the auditors many times are just like coders. They can't take isolated fact number 1 and isolated fact number 2 and put them together in a conclusion unless the doctor writes it. So the statement from the Medicare Claims Processing Manual is that cloned documentation does not meet medical necessity requirement for coverage of services rendered due to lack of specific, here's the key word, individual information. It can be considered a misrepresentation of the medical necessity requirement for coverage of services, and it will lead to denials for lack of medical necessity and recoupment of all overpayments made. So that's the potential. That's what we see out there. Next slide, please.
Thanks.
So I alluded to this before, and again, I'm sure that everybody or most everybody in the audience has seen this, but some of the ways the electronic medical record can lead to claim denial or fraud through poor design or improper use. The Make Me an Author tool. And this is a tool that where a attending physician can take the note of a medical student or the note of a resident, and all of a sudden use the Make Me an Author tool, and all of a sudden they become the author for that note. And as you know, Medicare doesn't pay for services provided by a medical student. The other thing that's missing are no areas for free text, and this is where the risk of documentation appearing identical is significant. And anybody that I talk to, I always tell them, you need areas for free text. And, docs will say, well, I'm a hunt and peck typer, and I can't take 15 minutes away from my patient, just to start typing something. Well, they do have voice recognition. They do have, and I hope there's nobody in the audience that I will offend as I say this, but they do have slaves that can be used. They call them scribes. Sometimes I call them slaves.
Okay, I get that.
The PAs, the nurse practitioners, who actually most of the time do much more robust documentation than the attendings. So then we have the copy and paste, and even copying and pasting a patient's signature, which is very easy to do in today's world of technology. That's forgery. No information in relevant areas, and then templates with self-populating fields, drop-down menus. And docs ask for this all the time, but the problem is that we have to think, medicine is so complicated, medicine is so multifactorial that you can't limit it to 5 items in a drop-down menu or 5 items in a self-populating field. We still need the ability to think, which we do, but we still need the ability to use an old phrase of mine called think in ink. Now it's not think in ink, now it's think in a keyboard, but the reality is that not everything is the same. Next slide.
Okay.
When we start getting into program integrity issues, security and privacy, encryption, backup, dealing with hackers, and the more sophisticated we become with these electronic medical records, the more sophisticated the hackers become. It's just I sometimes wonder, why do they do that? But I guess the answer is because they can.
Yeah.
How many times have you had a challenge in figuring out who the author was of the note that you were actually reading? You can alter entry dates. You can change them from the original date to the date of a visit. There's a couple of electronic medical records that I know of that are dating and time stamping an entry that cannot be eliminated from that page. And I get pushback from physicians about the fact that documentation can affect the quality of care. In my mind, in what I have seen, it truly can. And when you start, I had a conversation with a hospital one day, and I asked the question, so who is documentation for? One of the docs said, oh, that's for my CFO. That's so that he can bill for the service provided. And I had all sorts of answers, but nobody in that group of 12 people that I was talking to gave the real answer of who the documentation is for. The documentation is for the patient. That's what it revolves around. That's what we do. On the other hand, you hear people say, well, the only reason why you want me to do this stuff is so the hospital can make more money. You know, as we start getting into the quality measures of severity of illness and risk of mortality, the docs are being graded, and whether they like it or not, the grading has already started. Just go to healthcare.com and take a look at and see what doctor is in there and what's being said about them already. You can have a good doc who gives good quality care who doesn't document well, and his or her quality scores will look terrible. And in the future, that could potentially lead to a lot of problems. Number one, Medicare eventually may very well say your quality scores are so poor you can't take care of beneficiaries anymore. Commercial insurances are doing that. ACOs are doing that. There are some hospital employment programs that are starting to take a look at that. So it can affect quality of care. And as it says, cloning is a growing problem, and autofill and auto prompts, that's kind of a duplicate of what's been said before, using it for upcoding and code modification. Next slide. So the Department of Justice sent a letter to the American Hospital Association back in 2012. And granted, that's a few years ago, but they said that 55% of hospitals have already qualified for these incentive payments for adopting an electronic health record. But there's, as they say, and this is before the 2 midnight rule, that providers were using this technology to game the system, obtained payments for which they were not entitled. And the statement is false documentation of care is not just bad care, it's that word that you spelled at the beginning, Ernie, ILLEGAL. And did we ever resolve what was the proper spelling of permissible?
I think it's an I-B-L-E. Yeah.
You know, I saw a cartoon in a presentation too, and it was a caricature of a lady who had surgery, and the document was cloned, improperly cloned, because she was supposed to get surgery on her hips, and somehow the H got transferred into an L, and she ended up getting surgery on her lips. And
oh, gosh.
You have to see that in order to appreciate it, but, you know, it just kind of highlights some of the challenges that we're dealing with. So we talked about the upcoding. Next slide, please. Again, with the Department of Justice weighing in, the enforcement, and so the Department of Justice has a resolve to ensure that payment accuracy is enforced, and that they will prosecute healthcare fraud. And you know, everybody hates that 5-letter F word, But the reality is you see some of this stuff, and it can be considered pretty rampant out there. Although I must tell you, I do believe that most docs are trying to do the right thing. I believe that many docs have a tremendous burden of work that they need to do. And just like we can copy and paste on a text message on our phone, we also look for the ability to do that to save ourselves time. But we have to remember that we need to do what's right and accurate, even though sometimes it may be perceived as a burden. And the Department of Justice has criticized Medicare for not reviewing this stuff enough to the point that to look at it and consider future payment reductions is warranted. These efforts have contributed to record-high collections and prosecutions, and it's interesting to look at the prosecutions that are going on out there. The OIG has their top 10 wanted list, just like the FBI does. The problem is the top 10 wanted list for the OIG has well over 100 people on it. And so this is just a statement that shows what the prosecutions were like and how they're increasing. Next slide, please.
Okay.
So although the copy and paste feature can enhance the efficiency of data entry, it also, as we talked about, has the ability to inflate, duplicate, or create fraudulent healthcare claims. And, I hate using that word fraud over and over again, but again, these are notes that are not from me. These are notes that actually come from these different governing organizations. Only 24% of hospitals have a policy in place regarding the use of copy and paste. And what they're suggesting is that hospitals should put in place these audits and these policies in order to help reduce. And again, copy and paste is not necessarily a bad thing. It's the use of copy and paste or the abuse of it that can be the problem. So the key is that about 61% of hospital policies have shifted that responsibility to make sure that copy and pasting, when done, has accurate data. And there's nothing totally wrong about copying and pasting something, but editing it so that it's appropriate for what's being done. And then the next slide basically says, it talks about more about the OIG report, and I'm not going to go into it in a lot of detail because it's just a reinforcement of some of the things that we've been talking about. Next slide. So to summarize this conundrum that exists today, technology is helpful, but sometimes technology is not as helpful as we would like it to be. So the key thing to think about is the documentation should fit the reason for the visit. And I deal with this all the time because in the idealistic world, in the education that I give on a review of systems or a physical exam, AHIMA recommends for both of those 17 systems be reviewed. Now, AHIMA talks about it from a CDI, a documentation point of view. Do you really need a full review of systems for an infected cyst? Do you really need a complete physical exam for an episode of epistaxis? The answer is no. The ideal is yes. So where the balance of scales, where does that fit in? The other thing is if you have make me the author or make this a template, you have to be certain that the note that's copied is accurate and relevant. And I will tell you a personal experience that a person that I know had a child born that was tongue-tied. So that child went for the procedure, the name of which I forget the name, but went for the procedure to have that release done. So she went in to talk to the pediatrician. The pediatrician is reading the op report, and he starts laughing. And she looked, she got a little nervous. She says, well, why are you laughing? And he says, the op report as written, as typed, is accurate. The problem is it's the report of an operation on an adult, not on a toddler. So the notes have to be personalized. I had another chart that I reviewed where a 28-year-old came in with an episode of syncope, was in the hospital for 4 days. I won't go into the fact that 4 days for syncope sounds a little extravagant, but at the time of admission, in the history and physical, it raised the question about whether the patient was pregnant or not. Now, if you go through the doctor's notes, you go through the assessment, the plan, the orders. When you finally get to the end of that 4-day admission, including the discharge summary, you would never know whether that patient was actually pregnant or not, although it was resolved in the first day of admission. So it brings me back to that statement. The chart was surprised when the patient died. So can copy and pasting fairly static items like family history and social history be okay? Those are the items that get pulled in, the medications, et cetera. That may be very appropriate as in you try to make sure that it doesn't lead towards note bloat, but it does make it complete. Element documentation must support the codes being used. There needs to be auditing of the charts on a routine basis to make sure that it's appropriate. Consider the scribe or a nurse or the slave to help complete parts of the medical record, and don't copy the whole note, just the parts that are pertinent, and add some personalization to it. And that's the end of this presentation, Ernie, and certainly if there are any questions, I'd be happy to field them.
Yeah, there were a lot of comments, and I'm going to flash this. This has got Dr. Zelem's contact information here for anybody who wants that, and of course it is in the slide in his presentation. Now, I've heard that some people still have trouble getting the zip file that I post. If you don't have a recognized program to open them, go look for the ZIP program, and I guess I'm going to have to post a link to that under the box where you get them. But anyway, and anybody who can't get them otherwise right now, just put your email in the chat box, and I'll make sure they get sent to you unzipped.
You can probably copy and paste it.
Ernie, I just want to comment. This is a fantastic presentation of Dr. Zelem. This is what the auditors deal with all the time. I just had a client, not where I work, I had a client, and I went in, and they had 65,000 smart templates within one service line.
Oh my God!
So obviously nothing ever looks the same because Epic allowed them to make whatever they want. One of the things that I'm doing right now is I actually have joined up with a couple other people. We're teaching in a medical school, and the review of systems, and we're talking about cloning, and we're coming at it actually in the clinical skills group and saying, look, this becomes an ethics issue. Because if you're doing things like this and you're not pertaining it to the review of systems, and that's not pertinent to the review of system, you actually are moving into the wrong side on the ethics course. So we're spending quite a bit of time with the medical students in year 2, 3, and 4, going through documentation, cloning, copying and pasting. And one of the issues that Dr. Zelem pointed out is the key issue. Many of these EHRs were designed without contextual text. You cannot change it. It's a drop-down, it's a smart phrase, it's a cut and paste. And so therefore, it's very easy for the auditor to see that you misspelled it on day 1, and that misspelling went on for 7 days. It's not that hard. We can do that actually through computer-assisted reviews. Find the misspelling, put it in, have it find it. You just hit Control F, and there you go. So you can see many of these things. So it is very important that even medical schools, PA schools, even nursing schools start to understand that EMRs are there to help, but this type of behavior really is not pertinent. And my staff guy always says, the patient in the bed had better be the patient in that chart. And if you can't match the two, you've done it wrong. And so I get that every morning. Is that the person in the chart in the bed? So I think this is very, very pertinent information. There is a lot of gaming that goes on, and I think it's with intent. And I also see that, a lot of this is without intent. the system is so complicated. They're just trying to see their 30, 40, 50 patients in a day, and they're trying to clip stuff through, and they see this as an enhancement feature or an ease feature, these templates, not realizing what the end result was. So I think that's kind of something that when we show the medical students the end result of their record when we print it out, many of them are amazed, because they didn't think they did that much. So printing it out and looking at it is a real eye-opener.
I've been talking to Dr. Pahuja offline in the chat box, and he had some comments he wanted to make. Let me see, Dr. Pahuja, I'm going to put, let's see, hang on just a second. Okay, Dr. Pahuja, you can, if you hit *6 on your phone, that'll toggle your phone mute on and off.
Yeah, hi, Ernie, can you hear me?
Yes, I hear you.
Yeah, hi.
Yes, go ahead.
Hey, thanks for having me on, and wonderful presentation, Dr. Zelem, and great point, Bill. I think we are facing the same issues, whether it's big hospitals or small hospitals. The H&Ps are always done great. It's these progress notes that the copy-paste process goes forward, and sometimes it just misses it because of the change in the hospitalist schedules and the 7-on, 7-ons, the weekend hospitalists. And, some of what we're facing right now in some of our client hospitals is they are now getting post-payment DRG audit denials where they're saying, well, you put in acute kidney injury on day 1, but this is day 4, and that's being copied all over the chart. You're putting respiratory failure, you're putting use of sepsis, and each of these DRGs downcodings can be $3,000 to $4,000 to even $5,000. So there's just a lot going on, even though this copy paste may seem very benign to the providers, and I don't blame physicians because we have some of our healthcare providers and nurse practitioners who will use some great terminology. One that I'm seeing very commonly used is ECVD, and it took me some time to figure out what they were referring to. It turned out they meant extracellular volume depletion as a fancy word of saying, well, he's dehydrated, but it got carried over as extracranial and vertebral artery disease. That's what the ACCN used that as. And that significantly bumped up because the coders who were billing had thought this was a peripheral vascular disease, a carotid disease, versus it was just simple dehydration. So we are seeing a lot of these type of things, and I know you mentioned your personal experience. My daughter was in the ER for a left elbow pain, and turned out there was a hairline fracture, needed some splinting. But the record carried over instead of hand pain as head pain. 6 weeks later, I got the insurance company's EOB saying, well, we denied the entire stay because there is no indication for elbow x-rays for head pain. And that's when we went back to the ER record. Turned out instead of the hand, they had mistyped head, and that got carried over into the entire record, into the billing system. So it took a few weeks to figure that portion out. But
wow.
These are personal experiences. But CMS, Medicare, they have what you were saying, Bill, a linkage analysis platform, where they can see the linkage of words and they look forward to less intensity of service to show that there is improvement in patient care. So they've invested millions into that sort of software.
Wow.
Thank you very much for those comments. They're very appropriate. And I will add to that, if you copy and paste from another patient, even if it's a template, and let's just say you have a child who has some type of a respiratory tract infection, but somebody somehow accidentally, whatever, gets the term asthma in there, it's so easy to get something put into somebody's life insurance as a diagnosis, and if it's inappropriate to try it, get it taken out, is like you'd need an act of Congress, and even that isn't enough. So again, that's another dangerous issue too with some of these things.
I get the feeling that dictation is still the better way to go in all this, even with the EMRs. Is that like Dr. Johar was saying? I see in her comment in the chat room saying they ensure that they have the easiest dictation modules everywhere, so they can encourage good practices rather than using copy and paste. So
I've been. Go ahead.
I also
Dr. Zelem, go ahead.
I also see that Ron Hirsch made the comment: if you didn't ask it, see it, touch it, or think it, then don't document it. And I can't say anything more than I think that's a great statement. And I kind of, in many of my presentations, I go back to saying that documentation was important even in 1200 BC. Granted, it's a movie, but how many times in the Ten Commandments did Ramses say, "So let it be written, so let it done"? The other side of what Dr. Hirsch said is that if it wasn't written, then it wasn't done.
Right. And to the comment on dictation systems, I've been following and using the Dragon systems for about 12 years. Even the latest version that they released for the medical transcription right now is, they claim it's a 95% recognition accuracy rate, but it takes time to train it, at least 3 months, and it needs to figure out what you're saying. I think what Dr. Salvatore had mentioned about the new format of a SOAP note as an APSO note, where the assessment plan is written first. Few of our client hospitals have actually made the assessment plan as a free text. And what we're seeing now is the hospitalist groups are definitely writing something in it, but the subjective and objective seems to be the exact copy-paste carryover from a previous progress note or from the H&P. So there is a partial improvement with the APSO note. I personally am not a fan because they're writing what's going on, and the sequence of events doesn't support that assessment plan. You need to go back onto page 6 or page 7 to find out what now changed or what's the new complaint. But I think it's up to individual facilities.
That's interesting because Dr. Salvatore was asking about, anybody else. He says at their hospital, they're in Delaware. I think some time ago they went to starting to use the APSO format instead of SOAP. He was asking if anybody had experience with that. Dr. Zelem, are you seeing changes like that, or what would you say about the use of APSO versus SOAP?
Actually, I have to say I don't really see either one of them. Most of what I see is this is going to come across as strong, not meant to be as strong. Actually, what I typically see is a useless problem list. And what do I mean by that? The problems are identified. The treatment many times is identified not adequately. But what we're missing, and one of the reasons why we see these audits, is that there's no mention, there's no connection from that problem list into concerns and risk. What are you really concerned about? Do you have high levels or low levels of concern for what can go wrong? And what is the risk factor of the patient? And when you start putting that stuff in there, it's not just it gives a conclusion. And I kind of liken the assessment and plan to the opening statement of a trial. You take all of the information that you've gathered so far and you put it together and you say, this is what I see, this is how in the trial, this is what I'm going to go after and prove in the medical chart. This is what I see, this is what's going on with the patient, and this is how I plan to treat it.
Yeah. Dr. Zelem, this is perfect timing. I'm seeing a patient, a case review right now, 84-year-old, 15 problems in the assessment, and the plan is a one-line, awaiting sniff placement.
Oh, my gosh. How damning is that?
Oh, wow. That is amazing. But I'm sure, I too don't blame physicians so much for this because it's got to be confusing. I mean, you guys have to keep an awful lot of stuff in your head anyway, and then it's problematic, I think, because the auditors seem like they're questioning the judgment. Now, in some cases they are, whether they mean to or not, but in a lot of cases it's even like your scribes or your case managers or your nurse practitioners are, it seems like they're questioning the judgment of the physicians, and
Ernie,
that's usually not it. Go ahead,
Ernie,
Bill.
from a medical audit standpoint, some of these electronic medical records allow the auditor to get in that space where the old paper record never would have. So when there are disparities, when you see that the nursing notes, the physician says agree with nursing notes, the nurse is saying the patient's up ad lib, watching TV, enjoying time with family, and then the hospitalist is writing that, their blood pressure is 20, they're on all these drips, and they're about ready to leave the world. You get these dichotomies in the records. And so an astute auditor that is looking for these types of patterns is going to go right in and compare 2 days of nursing notes, 2 days of doctor notes, and are they even similar? If not, deny. So we're giving them the opportunity, and the problem is physicians aren't included in a lot of these builds of these IT systems. The IT people buy it, CFO buys it. There's a financial benefit to having this system, and then IT builds it up, and all they do is say to the physicians, well, we'll make you smart phrases, or you can own your smart phrases. You can make it look like what you want. And that's not necessarily a good thing to do. I mean, I think physicians should be intimately involved in the documentation processes of their practices and not let IT say, this is what we're going to do.
Yeah.
And to your point, nurses' notes, we talk about improving physician documentation. There should be a move towards improving nursing documentation too. And and again, nurses are busy also, but when do they write their notes? Most of the time at the end of their shift. And even somebody in the intensive care unit, the amount of time that they spend with the patient, and as another example, I love the one that you gave, but another example, the acute respiratory failure, which is a bad DRG to use to begin with, but the nurse writes sleeping comfortably. And from an auditing point of view, not a lot of auditors are looking at nurses' notes for validation, but there are some like yourself who are, and you get these dichotomies of facts, and it leads towards denials. Yeah,
definitely. All right. Well, listen, we're. Go ahead.
Well, no, I just typically say that, as you know from previous conversations, that helping to improve physician documentation is a passion of mine, and in order to improve it across the entire gamut, I think I would need 4 lifetimes.
Well, it's definitely going to be something we all have to work on. Yeah, it's not going to be something that gets solved anytime soon. I agree. I think the system has to change more than the physicians do. That's my opinion. But so anyway, well, listen, that's all we have time for. Yeah, we need to clone Dr. Zelem. That's what we need to do. So that's all we got time for today. But I do want to. Dr. Zelem, this is terrific. Great. I'll be happy to have you back on and talk more about it, anytime soon. And that's all. But that's all time we have. We have time for today. We will be back next Friday, February 12th, a special presentation that's about using predictive analytics and showing you how and why you should be using some incredible tools available in that to actually predict your risk of a denial before the claim goes out the door. So you want to watch for my announcements about that for next week. Thanks to everybody who's participated today. We had a great conversation in the chat box. Special thanks to Dr. Zelem, of course, for joining us, and Dr. Fahuja, and to Bill Malm for his help as always. Of course, many thanks go to our sponsors, the Health Law Partners, MedLinks Cost Containment, Aerolib Healthcare Solutions, Recovery Analytics, and the Council for Certification of Medical Auditors. There are contributions that make these broadcasts possible, so be sure and Visit their sites and thank them. Watch for my emails about next week's show. Share the links to our show with your colleagues and friends. And the last thing I want to share with you is that you shouldn't feel alone, because we're not the only ones struggling with copy and paste. There's plenty of other ways that copy and paste. I just had to include this picture of this German guy's tube of copy and copy paste. I have no idea what it means. Anyway, so it's a problem that exists all over the world, so don't feel lonely. Anyway, thanks everybody for listening. We'll see you next time when it's finally Friday. Have a great weekend, everyone. Bye-bye.